Attendees are in listen-only mode.
Good morning, everyone. It's Matthew Davis, your Interim Medical Director of Education. Thank you for joining us this morning. Today I'm joined with Dr. Sean Doran. He's one of the third-year emergency medicine residents down here in London, Ontario. And today we will be presenting a webinar on thermal burns. Now, just before we get going here, just a few points for those who maybe this is the first time you've joined us on a webinar. You'll notice in the right-hand side of your screen there is a control panel along the PowerPoint presentation. And within that control panel, there's a hand icon. And that hand icon, you can utilize that if you would like to ask a live question. You must have a microphone enabled for your computer in order to utilize this icon. There's also another chat box which you can ask a question in, and we will be able to answer your questions here today. Throughout the webinar, we will also have some poll questions, so please participate in answering those poll questions. And just a reminder, if it's a group of you watching the presentation together, then please just enter into the question box there, just letting us know that you are a group and just the individuals that you are watching the webinar with. And that way we'll be able to add you so that you can get your CE points. So with that, we'll get going on this presentation, and Sean, take it away.
Great, thanks, Dr. Davis. Just want to thank Dr. Davis, Southwest Base Hospital Program, opportunity to ride out with you guys for the last couple of years. I think I've met many of you here in London. It's always a treat to be able to go out and see what the pre-hospital environment is like. I also want to thank you guys for tuning in today so we can chat about thermal burns. And basically, we're just going to try and go through some of the main issues, get a little bit of a sort of a background understanding of the academic sort of aspects of burns and pathophysiology, and look at how we can classify and treat them in the field. Please feel free to ask any questions as they arise, and Matt explained how we could go about doing that during the presentation, and we'll go from there. Okay? So just to begin, we'll have a quick look at what our outline is going to look like. So that's basically the general format we're going to try and go through today. A little bit of backgrounder. We'll talk about some pathophysiology and thermal injury itself and how that actually works. We're going to look at some of the management and deal with some of the particular issues that may arise, not necessarily ones that you'll have to deal with in the field, but something to keep in mind or maybe contributing some of the complications or challenges you may experience while in the field or en route. We will look at pain management a little bit, eschar formation, how that's handled in the emergency department, look at our airway treatments, fluids, and so on. We'll also look at inhalational injuries, that they're very, very important components of any burn victim, particularly fire victims, and we'll discuss some of the implications there and get into some of the management issues that we need to consider. So a little bit of background statistics just to get an idea of the importance of this type of injury. Basically, we're looking at approximately 500,000 burn injuries per year in the United States. So if we loosely assume a 10% statistic conversion for Canadian data, we can estimate, it's a very crude estimate, but we can estimate approximately 50,000 burn injuries per year in Canada. That's very rough, but all the same, it's kind of the way that we try to attempt to convert some U.S. data to Canadian, just based on population numbers. We look at approximately 4,000 people die from thermal injuries per year. If we look at burn admissions themselves, we can see that approximately 40,000 in total, with nearly half of them being secondary to fire. There are other burn types that we're not going to get into today. That includes electrical burns, chemical radiation, and so on. However, the most common type of burn that you will see in the field is a thermal burn, and that's going to be related to fire. As you can see, almost half of them are secondary to fire, and another third are secondary to scalds. So it will more commonly be the typical type of thermal burns that you will see.
So Sean, just for all those numbers there, again, that's U.S. data. So I guess in Canada we can assume about 400 deaths per year?
I would say, yeah. I mean, the easy way to estimate these types of things, as many of us commonly do, is just take about a 10% based on the population difference, with the U.S. population being about 10-fold higher than the Canadian population. So we could assume, yeah, about 400 deaths per year approximately in Canada based on that. Please note that is an extrapolation, so don't go around quoting that in any papers or anything like that, or quoting my name backing that up, but that's kind of a rough, crude estimate for that. So the bottom line basically of this slide are thermal burns are the most common types of burns that are out there. They're most likely the ones that you're going to see. And overall, they have a fairly good survival rate, mainly because a lot of them may not be as severe as some other ones. But at least 10% of burn victims have burns covering greater than 30% of the total body surface area, which is quite a severe burn. Half of the victims of burns are approximately between the ages of 19 to 44, so it tends to be more of a young adult, middle-aged type of injury that occurs. Half of them are involve the upper extremities, which we can appreciate probably would occur for many reasons, using your hands to stoke a fire, to light a fire, to burn something, scalds, so on and so forth. And about a quarter of them are lower extremities, with another 17% or so being around the head and neck. Majority of these types of burns are partial thickness burns, which is an important little term to keep in mind that we will discuss shortly. What that means is less than 5% being full thickness burns, and we'll discuss these coming up in the next few slides. So I think the most useful thing to start off with is talk about the organ that's most commonly affected by burns, and that is going to be the skin. And just really a basic review of anatomy of the skin, looking at the major layers that are involved, particularly in thermal injuries. As you can see on the slide in front of you now, the three main regions have been highlighted. We have the epidermal region, the dermal region, and the subcutaneous tissue. So if we look at the epidermis first, this is the outer layer of the skin, and in this you see that the hair follicles will extend through this from the lower dermis and extend through the epidermal layer, and basically will cover through the sensory nerve endings and everything are found in this level as well. So certainly any sort of burn in this level is likely to be painful based on the sort of the physiology that our nerve endings sort of terminate in this region. If you go below the epidermis, we're looking now at more of this dermal layer here. Again, you see many of the components that are involved in the epidermis are also crossing through the dermal layer as well, including hair follicles, with arterial and venous blood supply at microvascular level. We do have nerve endings that are traversing this region as well. So again, looking at some of those things to give you an idea of the types of physiologic changes that might occur if there's destruction of this region because of the thermal burn. And I think it's important to note in the long run that our nerve fibers are basically covering this region, so certainly pain is going to be an issue. And then once we get below this dermis, we come into this region here, which is subcutaneous tissue. And this is basically more blood vessels, some fat tissue, which is noted by the yellow sort of region there. And this is basically going to be the layer that's kind of overlying the underlying muscle and bone. So the question, why is it important to consider these different layers? And the reason for that is that the different layers of the skin and the depth to which a burn occurs is significant in determining the severity of a burn. And ultimately that will contribute to our ability to properly classify a burn. So we'll get to this classification shortly, but we'll a few other general features that are worth discussing before we get to them. So if we look at burns themselves and how a burn occurs, we can break down the factors that are important in contributing to the degree of injury into approximately 3 different categories. We've highlighted them there on the slide in capital letters. And essentially it is the amount of heat. So the temperature that someone is exposed to is significant in determining the severity of a burn. The reason for this is I've indicated a couple different thresholds there. You can see the first one being greater than 44 degrees Celsius is a bad thing. The reason for this is once the cells reach approximately 44 degrees Celsius, protein denaturing begins to occur. So then essentially you start getting cell damage that's occurring. And this contributes obviously to tissue damage. Once you get beyond that, you're getting a situation where it is denaturing very, very rapidly and causing tissue necrosis rather quickly. So basically temperature is essentially an important aspect. The duration of the exposure is also important as well. I mean, generally being, it's kind of self-evident I think, but the longer the contact you have with the burn source or the thermal source, the more damage that can occur. And then the third aspect that's important to consider is the conductivity of the tissue. What this generally means in practice is considering primarily the type of skin that the patient in front of you may have. So if you have a very young patient or an elderly patient, their skin is much thinner and is more susceptible to burn injuries. So to expand that a little bit, looking at how the burn occurs, there's two main types of injuries from a burn. There's a primary injury, which occurs at the time of the burn itself, which we'll get into, and there's a secondary injury, which is kind of the types of injuries that ultimately most of our treatments are attempting to control as much as possible, because these secondary injuries after a burn result in further damage and increased morbidity and mortality. So if we look at the primary injuries, we can say that whenever there's a thermal burn on the skin somewhere, we end up developing these three concentric zones of injury. And I've tried to make a graphic on the right-hand side here to help us sort of appreciate what that looks like. If we look at zone A, which is the darkest region here in the center, this region here, so this would be what's called the zone of coagulative necrosis. So this is a region where there's been injury to this area, and this is irreversible. Nothing we can do will fix that. If we look at the next region now, we've got the zone of ischemia, which is this region surrounding the zone A. And this region here is the region that is reversible. That some of the treatments we have can reduce the amount of damage that's going to occur here and potentially save that tissue. And then the final zone is the zone of hyperemia. So this is a surrounding sort of red zone that is not damaged at the time, but will have a little bit of extra perfusion because of the injury.
So that's a great diagram there, Sean. And just remember, this is a 2D structure, so you'll see this on the surface of the skin, but you also have to think of what's going deep down into the layers. So just as the burns affect the surface, it's also going to affect deeper down into the structure. So the same kind of zones apply going in depth as along the surface of the skin.
Yeah, and I think that is really important to remember that this is something that you have to look at it and consider the layers of the skin that are involved as well. So that's kind of the basic sort of primary injury that occurs. Now the secondary injury, as I sort of previously alluded to, is the one that probably in the long run causes a lot of the continued damage and sort of contributes significantly to the difficulties in treating a lot of these patients in the long run. So getting into the emergency department and beyond. And what really that is a result of is, as a result of the initial injury or the primary injury, the immune system basically kicks in. And you get a lot of inflammatory molecules released into the circulation that basically become recruited to that area. Unfortunately, however, in many cases with inflammation that becomes uncontrolled to a degree, it causes its own set of injuries. The reason for this is these ROSs and RNSs, this is basically molecules that are released during the process of inflammation and secondary to some cellular damage that contributes to cellular damage itself. So these are reactive oxygen species and reactive nitrogen species. Furthermore, with all this inflammation, you get microthrombotic formation in the distal capillary beds. So you have these little tiny clots that basically block up the vessels distally and contribute to furthering potentially the ischemia by denying blood flow access to that region of cells. Furthermore, you get a lot of fluid shifting that occurs. Largely, you're going to have a lot of oncotic pressure changes as these inflammatory cells and these clots are forming in the vessels, and fluid is going to start moving into the tissues. And so you have what we commonly refer to as kind of a third spacing phenomenon, where a lot of the fluid that is intravascular is going to be shifting into the interstitial space instead, which can contribute to some hypovolemia. It can cause edema of the tissue, which further worsens an injury. And finally, because of the damage to the dermatological system of the skin, which is really a very large organ that's designed to protect our internal environment from the external environment, you have increased susceptibility to infection in the long run as well. Basically, that barrier to protect the interior environment from the exterior is damaged and can allow infection to take hold. And finally, contributing to all of this, you have a lot of metabolic arrangements that need to be managed in the acute and potentially short-term period after the patient arrives at the hospital. So I think that kind of covers a very basic sort of understanding of some of the important aspects to consider, a little bit of pathophysiology about the burn itself. Sorry, we'll go back there, my apologies. So pathophysiology about the burn itself. looking at some of the zones of injury and how injury can occur, the types of injury that occur, and a lot of the reason that we discuss this, have a basic understanding of those things, but also to have an appreciation of how this may contribute to burn classification itself. If you review this and look into this, there are many, many different burn classification systems out there. No one is perfect, and different ones can be used. However, in practice, there tends to be two common main burn classification systems that are used. One of them is the degrees of a burn. It really is primarily depth. So when we think of that 3 zones of injury that we had from a burn in the zone of coagulative necrosis, ischemia, and hyperemia, think of the degrees in that sense, and that this will be going down through the layers of the skin, which potentially contributes to what type of burn that you have. And the other system that's commonly used is the total body surface area involved. And this is normally listed as a percentage. And essentially you estimate what that is. You can use a chart like the one you see in front of you here. So sometimes we will have access to those and we can fill that out to try and get a fairly accurate assessment. Or you can try to attempt to understand these regions and just use the percentages based on those. And really in practice, when it boils down to at the end, often we'll bring it down to either a partial thickness burn or a full thickness burn. So we'll get into this in more detail, and we'll start by looking at the classifications of burns. So this is one of the most common burn classification systems. As usual, in many of these things in medicine, it seems to have been invented by some sort of French surgeon. It seems to be a very common theme for a lot of things out there in medicine these days. The system is primarily based on the depth of the burn into the layers of the skin. And although this is the most common classification system, please keep in mind that in general practice, however, we usually would divide these into 2 main categories, either partial or full thickness based on this system. So if we go through each of these in detail, the first degree burn. So this is going to be a burn that's primarily affecting that epidermis layer at the top of the skin, that outer layer of the skin. It's going to be generally characterized by erythema or redness and pain to that area, and it's going to heal most likely in many cases in days to weeks. So that's kind of what we're looking at here, primarily on the outer layer, some redness and some pain, and usually not a very prolonged healing period. We move on to sort of increasing severity of burns. The next type of burn that we would look at would be a second degree partial thickness burn. So this is now involving this slightly deeper layers. So if we look on the diagram to our right, we're seeing that now we're sort of seeing a bit of an appearance different here. We have affected the epidermis, and we're going through the epidermis. It's going to appear red and very blistered. So we'll have these blisters on the surface that you can see in this diagram. And basically we are going down now into this dermal layer. So we know that the depth of the burn now is much deeper than the previous one. It's going to appear wet or moist. And then if you were to put pressure on any of this wound, which I wouldn't advise unless you absolutely had to, it should blanch or turn white with pressure. And it's going to be very, very painful, largely because we know that those nerve endings are all through this region here, so there's been damage to those, but not enough damage that they're completely non-functional. So they're very active in transmitting pain signals, and they should heal in approximately a time period of weeks. When we get into this second degree partial thickness deep type of burn, now we're getting in, essentially taking that second degree burn that we just talked about and making that even more severe. So now it's going to go very, very deep into the dermal layer. It hasn't crossed into the subcutaneous tissue layer yet, but it's certainly very, very close. Generally with these burns, you will not typically see this type of redness that you're going to see here. You'll see it more whitish in appearance, which is a little unusual, with some redness throughout. It's going to be much less moist or wet looking. It's not going to blanch if you're to put pressure on it, largely because it's already kind of blanched on its own. It can heal, but it takes several weeks minimum to heal. And these are the types of burns that often result in scarring and contractures. In the long run, patients with these types of burns will likely need to go on to excision and skin grafting with plastic surgery. And over time, it does have the potential to develop into a third-degree burn, which really is the worst type of burn. So essentially, this one is, this has become a very, very serious burn. Certainly, the second-degree superficial burn is serious as well. However, this one is getting into the category where you could start to have some very, very serious long-term complications from this. Particularly in children, this type of deep deep second-degree burn can cause significant scarring and contractures for kids, which can be problematic in the long run. And then we get to our last two burn categories, which are getting a little bit easier, I think, to understand. The second degree being the most sort of complicated in terms of how it's actually working. But a third degree burn is this full thickness burn. And this is the type of burn that is extended through both of the skin layers, the epidermis and the dermis. It's going to be stiff. It can be white or tan in color. It's going to have that dry, sort of charred appearance to it. It does not blanch. And fortunately, the one positive side in this is they're generally not as painful as some of the other types of burns, largely because you've now damaged the sensory nerve fibers that have been moving through those layers almost completely, and they're not transmitting any more signals. And then the last category, which we don't really discuss very often, but is a fourth degree burn. And this is the type of burn that has extended through all of the skin and subcutaneous fat. And when you see this type of burn, you will see underlying muscle and potentially bone just exposed there. The skin is going to be stiff, it's going to be very charred, and there's going to be very visibly thrombosed and clotted off vessels.
Okay, so I think we had a question there. First off, I understand we've had a little bit of difficulty with the microphones here, and there may be some challenges in hearing what we're talking about. So if there are any questions about what we've talked about to this point, please, type them in, or if you have a microphone and want to ask them, I would encourage you to do so, just so that we can know that some of the earlier stuff we talked about has been covered fairly well, and that there are no outstanding questions from that. So maybe I'll give just a moment here just to sort of take a look at those things. Okay, so we did question one there. Okay, we're time for a poll question here now. Okay, well there we go. So everybody got that question right, and that's great. It means that we probably covered most of the earlier stuff, and despite the technical challenges that we were having, most of the information got across. So that's correct. That one is second degree partial thickness burn. Fairly straightforward question, but we need to ensure that we ask a few things just to clarify and make sure that there's no confusion about that. So we'll move on from that point. So if we get on to the next stage of the discussion here, is going to be looking at some of the classification of burns, but now extending that to beyond just the depth of the burn, but trying to get an estimation of the total body surface area involved. So this is an example of one Lund-Brauer chart. There are differences between a lot of these, but essentially this is going to give you an estimation based visually on total body surface area involved. Try not to look at the specifics on there. There are some differences in this particular chart. This is important for a few reasons. One of them is for us in the emergency department, it certainly helps guide our fluid resuscitation. So as we will see, the formula we use to calculate the fluid requirements in burn victims is based on the total body surface area for each patient. Also, criteria for referral to a burn unit is also partially based on the total body surface area involved. Important to note when calculating this, we only go for second and third degree burns. First degree do not count, so we do not use this for anything other than second degree burns and worse. And there is one sort of quick estimation because nobody ever has this chart in their head all the time, but essentially we could use the palm of the patient's hand, including the fingers, to estimate the total body surface area, basically that total being of the palm and fingers of the patient being approximately 1% total body surface area. So the other sort of quick estimation rule is the rule of nines that we could use. It is an estimation method, and if you look here, what you'll see is that there are differences between adults and pediatrics, largely because the pediatrics have a larger head, so that there is more percentage TBSA involved in any injuries to the head in a pediatric patient. But essentially for adults, this is kind of the number format that you could remember. It's fairly straightforward. Anterior and posterior trunk each 18%, 18% for each lower extremity, 9% for each upper extremity, 9% for the head, and 1% for the perineal region. So essentially you could give a quick estimate based on looking at the patient of what the approximate TBSA involved is.
And again, as you said, Sean, it's just an estimate. It's not a precise science when estimating the total burn area. So again, just your best estimate, that's all that's required. And again, in the emergency department, it's the same when we pass that information on to the plastics team. It's an estimate, not a precise science.
Okay, and yeah, so we will move on from that there, and certainly use that if you want to, and certainly if you have that information when you patch in or call in, if you're doing so, it's certainly very helpful, and the earlier we have information, the better. So basically, if we look at these different classifications of burns based on TBSA, it's primarily a severity category. You have a mild burns, which are generally less than 2% full thickness, less than 10% total body surface area. So now we can see that our degrees of injury and our TBSA are sort of being combined to help us sort of determine how severe an actual burn is, likely for management of that patient in the longer term and where we need to send them or keep them in the emergency department or in the hospital or so on. Kids and elderly patients have a slightly different threshold for when the burn becomes more severe, which is just useful to know. And likely when you get in these mild categories, these are ones that it can be managed as an outpatient. So you see this man here, you know, he's got some erythematous regions. You know, it's possible that he had some blistering, but we'll assume for the sake of the discussion here that he did not, just some red regions. A fairly extensive region on his shoulders, however, you know, likely not that severe, and likely could respond to sort of conservative treatments and likely be discharged as an outpatient. As we get into more severe burns, so we're increasing now based on our degrees categories and our TBSA. And these are getting into approximately 2 to 5% of the area involved being full thickness burns. Any sort of high voltage burn or electrocution injury from a high voltage. There was one recently here in London. That was in the newspapers. Any inhalation injuries certainly are increase the severity of burn regardless of how severe the skin that may be affected. Any circumferential burns, largely because there are complications that arise from circumferential burns that we will discuss shortly. Any comorbid diseases that the patients have certainly contributes to how severe or how serious we need to take each burn. And again, the total body surface area involved for moderate burns, you know, varies between adults and kids and elderly patients. And once you get to this, most likely this patient is coming into hospital. And if you see here, we've got this very moist-looking burn here. We've got a region that's erythematous, likely some blisters at some point or the other. So at this type of burn, we would be suspecting that this is, a superficial burn, likely a second-degree burn at least. And then when we get into the more severe burns, we're looking at greater than 5% of the burn area being full thickness. Again, high voltage burns are a problem here. Any burns to sensitive areas are important. To kind of make the exceptions to the rules of total body surface area involved. So any burns to the face, the eyes, the ears, the genitalia, or over any of the joints, we tend to take more seriously, as there can be other complications associated with those in the long run that we need to monitor for. And anything that's associated with significant trauma certainly increases the severity of that burn. Again, note the difference between total body surface area between adults and children. So the bottom line being having a lower threshold to increase the severity of burn based on TBSA in children and elderly patients. Okay, so we're going to have a question here, I think, now.
This brings us to our next poll question. So we have a 55-year-old male with superficial degree burns to his anterior chest and right upper extremity. What is the percentage of total body surface area? So go ahead and make your selection. I'll give you a couple more seconds to vote. And here are the results. So we have 17% say 18%, 4% say 36%, 75% say 27%, and 4% say 45%.
Okay, so we see that most of us got the correct answer there, which was C, 27%. Some of us did get, we had some people choosing 18%, 36%, and 45%. So maybe we could just quickly go over how we came up with that calculation. And in all fairness, if you look at this slide here, this is the Lund-Brauer chart that I used to generate this question. As I mentioned at some point, there are some slight variances in some of these charts. So I don't think it's completely inappropriate to be faulted for potentially getting a slightly different value. I would say the 45% is probably a bit of a stretch. Certainly the 36 is getting there too. 27 and 18 are a little bit more realistic. But essentially, if we look at this, we have a patient that has a burn to his anterior chest, giving us an 18% TBSA involved, as well as the right upper extremity, which is 9% TBSA. Just adding the two together, 18 plus 9%, we get a total of 27%. So as long as we have an appreciation of how to calculate that, there may be some slight variability, and it is an estimate. So in reality, if you looked at this and said about 27 to 28% or so, most people would be happy with that. It's a rough estimate, but technically if we're using this chart here, that's the correct answer for that question. So we'll move on. We'll try and get a little bit more and transition a little bit now more into the management of these types of things. So, you get a call, patch in, code forward, a middle-aged man in the house fire, police and fire en route, please respond. And this is the point where maybe, after today anyways, I'm hoping that you'll sort of go through your mind and try to refresh some of the knowledge of thermal injuries that you've gone through today. And hopefully you'll think about these things en route so that when you arrive on scene, we can quickly decide what the important steps are and what we need to do next. So we're going to get into some of the generalized management, discuss what to do on scene, what sort of medical directives if they apply, what sort of non-delegated acts if they apply. We'll get into some of those issues and discuss some of those things and what you should be doing in the field while getting the patient ready to get to the hospital as expediently as possible. First thing, as always, we need to assess scene safety. You guys are important to us. We don't want you going into any situations where you could be injured or put yourselves at significant risk. in an attempt to help with the patient. We don't need more patients. So I think that's a very important factor. Probably in a situation where there's a lot going on, it could become easy to overlook this, but please, be careful out there. We don't want extra people coming in or any of you guys getting hurt out there. So the second step is, in general principle is you need to try and stop the burning process if possible. We need to move, and part of this stopping the process is removing any burnt clothing that might be there if it is safe to do so, or won't cause any further damage to the skin by being stuck to the skin or so on. Any chemical injuries we want to douse with water significantly. However, I have put a couple asterisks there, and there's a very specific reason. There's one situation, a particular type of chemical that water will likely be not helpful, and actually may be contributing to worse harm. It's a bit of a side note, but any sort of alkali injuries or heavy metal injuries that you're aware of, water will not help that. The other point that's really important here, and I think considering these scenes can be very dramatic where a lot has happened, any additional injuries that could be involved, I think it's important to think about what the patient may have experienced prior to EMS arriving, and what they may have attempted to do or what may have happened at the time, and if there's been any falls or any other injuries that may have occurred, so that we're protecting them from those things as well and not getting distracted by any of the obvious injuries, which can be quite dramatic, as we'll see in some of the upcoming slides. And of course, at the bottom of the list, although it should always be at the top of the list, but I think there's a lot to think about when you arrive on scene first, is we need to look at the ABCs, and that's our primary concern, is to assess the airway of the patient, assess their breathing, assess their circulatory status, and make sure that they're as stable as possible. So this could be the type of scene that you show up to. Hopefully it's a little bit towards the end of this and things are a little bit more under control, but this could be something very similar. A patient may have come from an environment that looked just like that 5 minutes before, 10 minutes before. They may have significant burns to their body. They may be having difficulty breathing. There may be all kinds of things going on there. And I think at this point it's always useful when you pop up to the scene and as you're going there to stop and think for a moment, what are the things that I think I should be doing to prep for this patient, or what are my issues that I need to be concerned about? And hopefully after today, that's what we'll be able to do, is sort of have a nice condensed list of the things we need to consider right off the bat and sort of be watching out for and be mindful of. So the first thing I think is important is, as I mentioned, think about the scene and what the patient may have endured prior to showing there. Did they attempt to jump out of a window? Did they fall down some stairs? Is there some type of injury to suggest that we need to put C-spine protection on this patient so that basically we're not worsening their outcome by neglecting something important like that? We need to do an airway assessment early and usually repeatedly just to see where we're at. These can progress in these patients. And we have to ask ourselves, is there a possible inhalational injury that's involved? And we may consider Ventolin if we think there's a significant component of bronchoconstriction as evidenced by wheezing. It should be, if we can, obtain a peripheral IV, preferably in a non-injured site. If we can get access in a region that is not burnt, that is preferable. However, if that is not an option, well then that's understandable and we do what we have to do. Certainly fluid resuscitation as required, but only if the patient is hypotensive. That would be basically following in medical directives for that, and that's the only time that we could consider giving a bolus in these patients. Pain control can be an issue. Certainly if you're an advanced care paramedic, you may wish to consider morphine or fentanyl, depending on what you have in your rig. And I put in here eschar formation as well. It's not something that in the field you will have to treat. However, it may be something to consider if you're running into trouble, that there may be a component of an eschar that's contributing to some of your difficulties. And certainly if the department is aware of those things en route, then it can help us prepare for that type of instance.
And Sean, maybe can you just explain what you mean by the eschar or eschar formation?
Sure. Sure, I can go on here. I have this further down, but essentially an eschar, actually, Matt, if you don't mind, we'll get to that in a few seconds. There's a slide coming up in about 2 or 3 slides, and it has a picture of an eschar, and I think it's probably easier to talk about it with the image in front of us. So we'll try and burn through some of these slides. I know we've got about 20 minutes left, and I want to try and make sure we get through everything here. Okay, so first thing, for us in the emergency department with any burn patient, one of our most important things is fluid management. mainly because we talked about this in some of the physiology or the pathophysiology of a burn, that we get a lot of fluid shifting so that the patient becomes intravascularly depleted. There are many formulas out there that have been tried and tested, and there's a lot of sort of disagreement about which ones are the best to use. They're all, again, rough estimates of how much fluid a patient needs in a burn. And the reason for this is they are at significant risk of becoming hypovolemic because of fluid shifting. And so the most common one that we use in North America is this Parkland formula. We tend to prefer lactated ringers in these patients. It's a little more physiologic. And essentially we're going to be trying to estimate that total body surface area, which again you can see why that becomes such an important calculation for us. And we want to give that at 4 milliliters per kilo over the first half within 8 hours. And the remainder of that over the next 16. Obviously, it's a rough estimate, so when we have these patients anything longer than just the emergency department period, we're going to be adjustment to the vital signs. And we're going to be using smaller burns being over-resuscitated and larger burns being under-resuscitated. Okay, so again, this is more of what we're thinking about in the emergency department, but certainly in the field, if your patient does become hypotensive, remember that it could be because of some fluid shifting, that they are going to be intravascularly hypovolemic, and if they are hypotensive, and you can go ahead, give a fluid bolus that's appropriate, or patch in and talk to the emerge doc to see if they think that would be helpful. Okay. Next issue we want to get into a little bit is a little bit of pain management. Again, as we saw, any of those burns, first, second, and third degree burns, the latter being less painful typically, or at least described in the text. Whether it's true in reality is sometimes a little bit different to determine. Either way, pain management can be very important. These patients can be in a lot of pain, and so any paramedic that can place an IV and their patient is a significant amount of pain, following your medical directives, it could be appropriate to administer some pain medication, either morphine or fentanyl probably being the best. Again, just to clarify, that is for our ACP paramedics. Remember that if you are going to be giving any pain management or any opiate medication to manage pain, that can contribute to hypotension, so you need to be very careful to watch the blood pressure in those situations. And that's an important issue. The reason in the long term why pain management, and certainly something we'll take seriously once the patient arrives in hospital, is that there are studies do demonstrate that in patients where there has been inadequate pain management during their hospital stay, they are at a higher risk of developing post-traumatic stress disorder secondary to the injury, as well as chronic hyperalgesia syndromes where they suffer pain in the long run. Still, of course, and reminder that the most important things, however, are the ABCs, the airway, breathing, and the circulation. So again, some of these things in terms of pain management fluids, certainly if you have time and it's appropriate and you have the skill set and the medical directive to support you to do so, then please go ahead. However, if you don't, the best thing you can do is get the patient to the hospital.
I'm just going to jump in here, Sean. We just had a couple of comments from the audience, some practical tips here. Again, yeah, you guys are out in the field, and we're not aware of all these things, but some of them we do employ in the emergency department as well. One person wanted everyone to just be aware that just be sure that fire is often preoccupied with the fires themselves, and they might not inform you or recognize potential patients. So again, that's something for you to be aware of, according to one of your colleagues there. And also another tip was to rub some like a menthol-based product around the nose, under the mask, just to help prevent that smell of that burned flesh. And again, we do similar things in the emergency department with those bad smells. Things like menthol products or all different products, just something to overcome that smell. So just a couple of tips there from your colleagues.
So we just
I actually really like that first tip too, because it feeds into the presentation fairly nicely, actually. So keep in mind that the fire may not recognize or inform us of potential patients. And I think that's a very important feature, as we'll see when we get on to inhalation injuries. This is something that can be developed, and as paramedics, you're mindful of this type of injury that may not be obvious to someone who's not trained medically. Anyways, moving on.
Well, can I just jump in and ask a quick question?
Yes, certainly.
There's a question composed here by Kelly. So why is ringers preferred for treating burn patients? Also, should an IV be started for a patient with evidence of a burn with crackles present, assuming the patient is hypotensive?
The reason lactated ringer is preferred is it's generally a little bit more physiologic than normal saline. So the levels of sodium and potassium are a little more reflective of what our serum sodium and potassium is. That's one of the main reasons why lactated ringers is used in these cases. Sorry, and the second part of the question was?
So should an IV be started for a patient with evidence of a burn with crackles present?
For pain, okay. So the IV start basically would be, one, why would you be starting the IV? So if it's for pain control, then that shouldn't affect if there are crackles in the bases of the lungs. Certainly there would be some concern if the patient has pulmonary edema, which is what is being suggested by the crackles, as well as giving fluid to that patient and potentially worsening the edema. Again, I think it's important to look at the medical directive that we have, and that if the patient is hypotensive, it may be appropriate to give a fluid bolus. Certainly if there's some concern about that based on the features of pulmonary edema or crackles that makes it worrisome, it may be worth patching in and speaking to whoever's on that day or answering the phone.
Anyway, just to follow up with that, it'd be very unusual to hear crackles in burn victims. Again, you know, pulmonary edema secondary to congestive heart failure. You can get acute respiratory distress syndrome in these burn patients, but that's not something that's going to occur acutely. That's down the road where their lungs start sounding wet. So, you know, usually these patients, if at all, they may have some bronchoconstriction, some wheezing. More worrisome is if they're stridorous, meaning upper airway involvement. And again, Ventolin is not going to have much effect on, or any effect on, airway edema itself. The Ventolin is just going to have an effect on the bronchoconstriction if there's some reactive airways occurring secondary to the smoke inhalation.
Okay, that's good questions, though. Thank you, and some very good comments. We had discussed briefly earlier about eschar formation and what that actually was. So essentially what that is in patients where they have significant burns, they can have this thickened, charged skin. And if that is circumferential or around the neck or the trunk or on the limbs, this can certainly impair blood flow and make breathing more difficult. And what you see in this picture here is basically a patient that has significant eschar to almost entire upper body, and at the emergency department they performed what is called an escharotomy to basically release the tension on all of that skin so that breathing can be normal and that blood flow is returned to the extremities. If we move on into one of the most important issues to consider is airway and breathing. We're very concerned about airways in these patients. Often we're particularly concerned about the loss of the ability to oxygenate or ventilate secondary to these inhalation injuries. They can have a rapidly progressive edema, so we're very concerned about securing airways in these patients, but they're very, very scary airways, so we don't really prefer to do these in hospital with anesthesia backup, lots of adjuncts to our primary laryngoscopy, so that if we run into any trouble, which we always expect in these types of patients that we almost certainly will, we have lots of backup, lots of options for us. But essentially, bag valve mask ventilation and oxygen is may be needed for these patients. Consider Ventolin if there's a component of bronchoconstriction. We move on, so the inhalation injury is what we're really concerned about in a lot of these patients, and I think what one of your colleagues was alluding to when he mentioned fire not being able to identify potential other victims. These are about 5 to 35% of burn victims. It's a major cause of morbidity and mortality. The clues to this diagnosis will be facial burns, carbonaceous sputum, wheezing, but more importantly stridor, suggesting upper airway obstruction, hypoxemia, and a little bit based on the history if there's some closed spaces that are involved. So again, although airway control is important, as we're suggesting, anytime the thought of putting a tube in crosses your mind and you have the skill set and directive to support you potentially of doing that, recognize that this is something that terrifies Matt and myself in the emergency department, and we have lots of backup there. Respiratory therapists, anesthesia is going to be involved. So again, if a tube is being considered, it is absolutely a very, very, very last resort. Okay. If we go on with inhalation injuries, essentially with any smoke inhalation, there's two main toxins involved: carbon monoxide and cyanide toxicity. We'll talk a little bit about how they operate. The big clues to these diagnoses is the patient has been in a fire, there's been lots of smoke, and they have altered mental status, that being either confusion, decreased level of consciousness, seizures, or coma, and they have poor oxygenation causing the altered mental status, of course, and some cardiovascular instability. But really the big thing is patient's been in a fire, there's been smoke, we have to assume inhalation injury and possible CO toxicity and cyanide toxicity. Right now?
So we've had another question come in here from the audience, and just someone asking, is there a topical pain control in the emergency department? No real topical pain control that we use. The main thing is, for these severe burns, we're going to use systemic parenteral opioids, dilaudid morphine, fentanyl for the pain itself. For the more minor burns, again, it's going to be oral analgesics such as Tylenol number 3s, Tramadol, Percocet, and for the very mild ones such as your sunburns, your first-degree burns, it's going to be an anti-inflammatory like Advil, ibuprofen, Motrin, Aleve, just to help reduce the inflammatory process to give them some relief from the pain. So no real topical stuff as such a topical lidocaine patch are not used in these patients.
Okay, and moving on a little bit, I had some slides about cyanide toxicity and carbon monoxide toxicity kind of at the cellular level. I think I'm going to sort of skip through those because I do want to get through a little bit more of the sort of the field notes and the sort of the practical applications of directives and what regulations are out there to support you. Essentially, in both of these cases, I think that the key to this is that cyanide is going to affect the mitochondria of the cells, and essentially you could think of it very loosely and imaginatively as suffocation at the mitochondrial level. Basically blocks the ability of mitochondria to make energy for the cell, which prevents the cell to be able to extract oxygen from the blood. Carbon monoxide, a different type of mechanism, however, in reality results in a similar type of process where basically it's affecting the specific cells in the body's ability to handle oxygen as it needs to perform its function involved in overall body respiration. So essentially with carbon monoxide, you're binding to hemoglobins more tightly than oxygen would, and so you prevent the red blood cell from being able to carry oxygen. So slightly different mechanisms, but essentially resulting in impairing any specific cells in the body's ability to provide oxygenation for the cell. So again, treatment in the field, most important things to do is a quick sort of review of some of those things. Consider possible inhalation injury, consider possible inhalated toxins at play, especially carbon monoxide and cyanide. Treat with oxygen therapy, get to the ED as soon as you can, and manage the ABCs. So we're going to transition to some of the specifics out there for how you can treat these and what guides your treatment of them. Basically, burn victims fall under the category of the Ministry of Health and Long-Term Care BLS manual, in that there's a region on thermal burns. I believe it is section 4, and you can read that if you have time, and we'll discuss those issues. If you have medical directives as an ACP versus a PCP, airway, bronchoconstriction, and endotracheal tubing, it will fall under that. IV access, pain management, and fluid resuscitation will fall under specific medical directives of ACP or PCP.
So a quick poll question coming in here, poll question number 3. As an ACP, at what point should you consider intubation of a burn victim? So just give a couple more seconds here for you to reply. And the results are as follows. So detection of wheezing stridor, 0%, tachypnea and carbonaceous sputum, 0%, O2 saturation, 92%, significant stridor, 4%, and ventilatory assistance airway control failed BVM, 96%.
Nice. I'm really glad you guys got that question right. We were getting up to that point, and I think that question popped in the wrong point in the presentation, but that's exactly right. Basically, the only time you should consider intubation of a burn victim is as an ACP, you have definite need for ventilatory assistance and airway control or other airway management that is inadequate or ineffective. So essentially that is outlined in the ACP directives in your paramedic handbook, so that is absolutely correct. So if we move on with the field notes, again, personal safety precautions. You need assistance from fire as need be. If the patient is in in a dangerous environment, we need to attempt to move them to a safe environment if needed. Again, C-spine precautions may be indicated, so think about those things. We need to assess for any life or limb-threatening situations suggested by severe burns, smoke inhalation, or concurrent injuries. We need a primary survey of the scene, and transport decision needs to be made, as long as an assessment of history if possible. When we're doing our secondary survey physical assessment, estimate the severity of the burns based on the depth of degrees that you suspect, the total body surface area involved. If there's an extremity involved, assess the neurovascular status of that extremity. Any smoke inhalation or upper airway injuries need to be considered and treated accordingly. Assess burns to eyes. However, in this case, the role is primarily to inspect them only. Vital signs, including GCS, are very important, and transport decisions should be made. In terms of managing these patients, part of this will be according to the general standard of care, the trauma format. So there'll be guidelines in that can help guide what you're going to be doing in those situations. In terms of burn-specific issues, again, we mentioned this, and this is really kind of the meat of that section in the Ministry of Health and Long-Term Care BLS manual, is that this is really the treatments that we should be providing to these patients in the field. The first step is, again, if safe to do so, you need to attempt to stop the burning process. We should extinguish any flaming clothing or skin, and we should try and smother that or soak it. We should attempt to remove any smoldering clothing, any hot jewelry, any watches or rings that may be attached to the patient's skin and causing further damage. And any clothing that may be sort of glued or stuck to the skin because of the burning, we should try and cut around that and leave the part that's actually in contact or stuck to the skin in place. We should provide a high concentration of humidified oxygen to these patients, and we should also be following ALS patient care standards. We continue with the management, and this is kind of where there's some very specifics outlined by the Ministry of Health and Long-Term Care. First and secondary burns that are less than 15% of body area, we should be applying wet, sterile dressings or clean, wet sheets to those types of burns. So that's the dressing we want to apply in the field. Anything more than that, so if it's anything beyond a first or second degree, less than 15% TBSA, we need to apply a dry, clean sheet. We need to elevate the affected area if practical, and if the burn dressing is to be applied, we need to leave the blisters intact. Cover the affected eyes if needed with moist dressings, and rapid transport if indicated. En route, monitor these patients carefully. Frequent vital signs is very important. Particularly, we're watching for any evidence of decreased respiratory function or any evidence of hypovolemia that may require treatment. We need to reevaluate them frequently. Concurrent injuries management, of course, if there's any C-spine precautions to be considered, any other injuries, fractures, anything like that, they need to be thought about and looked after as you would in any other patient. Constantly keep a close eye on that airway. Remember that if you have the skill set, endotracheal intubation is a very, very, very last resort. I can't stress this enough. Any suggestion of cardiovascular instability needs to be monitored for as well. And as we said, you need to utilize our ACP and PCP directives as needed. Potential A's that may be utilized if needed. IV and fluid therapy medical directive is systolic blood pressure below 90. The endotracheal intubation medical directive for our ACP paramedics, again, that's like we have lost management of the airway. I'm sure of that, is a last resort effort. Mainly because these are very risky airways and very problematic and generally very difficult to do. Certainly the bronchoconstriction directive may apply, and your pain medical directive as an ACP will apply as well. And I believe we have a question now.
So our last poll question is, patient with burns to the right arm and half of the left arm, what is the percentage of total body surface area, and what is the appropriate field dressing? Okay. So it looks like 96% say 13.5%, and wet sterile gauze.
Okay, great. So that is the correct answer. That's based on our discussion of the TBSA previously in earlier slides, as well as the BLS manual outlining how we should treat those burns, which if we go back a couple slides again, basically saying that in summary, anything less than 15% first and second degrees, wet sterile dressings or a clean wet sheet. Anything more than that, we're looking at a dry clean dressing or a dry clean sheet. Okay, we have a couple questions that Matt's going to discuss here in a moment. Hold on a second, please.
So one comment actually came in from Dr. Mike Peddle, the local medical director here in London, and he just informed me that London Fire is moving towards putting gel burn dressings on their vehicles. And these dressings, I guess, have been shown to decrease pain and cause cooling without the hypothermia effects of applying actual fluid to the body itself. So that coming out shortly here in London. I'm not sure about the other regions if other fire services are doing that as well. Another question that came in regards to hyperkalemia and the effects that lactated ringers has on the burn patients, and a question of whether or not the potassium in the lactated ringer solution can lead to further hyperkalemia. And the concern is with these burn patients, they have a lot of cellular destruction and potential for hyperkalemia. Again, this is not in the acute setting, so the hyperkalemia, it's going to occur down the road, not something that occurs right away. And the luxury we have in the hospital is we have access to laboratories and doing blood work on patients. So, you know, electrolytes are something that are going to be measured continuously throughout the patient's stay, just because there's going to be a lot of electrolyte shifts. The potassium found in lactated ringer solution, again, is very physiological. It's a very small amount of potassium, so it's not going to have much of an effect on the patient's overall potassium stores. Again, the use of lactated ringers in burn patients, there's a lot of different people out there who say, you know, it's lactated ringers. Other people say use normal saline. The science behind it isn't the greatest. It's a bit of medical dogma. So again, is there a right or wrong answer? You know, there's pros and cons of using both lactated ringers and normal saline, so it's something that will always be debated. And again, the most important feature of it is ensuring that they are appropriately fluid resuscitated.
Okay, so I think that pretty much covers most of what we wanted to discuss today. Again, in brief sort of overview summary of the management aspect of things, certainly scene safety is important, managing the airway is important, considering any concurrent injuries, fluid if hypotensive and you have the directive to support it, pain control if needed and you have ACP training, certainly transfer to the emergency department as soon as possible, and any severe burn victim, as many of the issues that happen with these patients can evolve very, very quickly, and it's best to treat them in a safe environment with lots of resources and support to back you up. So that would sort of summarize our overall management issues with these patients. Again, we talked a little bit about some of the pathophysiology of burns, how to appropriately classify them, some of the specific issues that can arise, how to deal with some of those issues. We looked at some of the directives that support what you can do in the field, including the BLS manual from the Ministry of Health and Long-Term Care, Section 4 on thermal burns, and we talked about some of the issues that you would need to consider in all of these patients. Hopefully this has been a useful seminar for you guys. If you have any questions or anything like that, please welcome them.
So Sean and Matt, we have a couple of questions that have come forward. So one is from Thomas here. It says, we've used water gel for years and mindful of its possible hypothermic effects. I have found it excellent even when I initially thought I was going to have to consider adjunctive narcotic pain control. So it is out there and people are using it.
Great, thanks for sharing that with us.
And why a dry dressing over third-degree burns and not wet?
Again, with third-degree burns, if you remember back to the anatomy of the skin, you're down into the subcutaneous tissue. So the fact is your skin acts as a barrier for keeping the body warm. So you've lost all these layers. Now applying something damp and wet, it's going to conduct more heat, and the body is going to lose more heat. So that's why, based on the BLS manual, they recommend putting a dry sheet over it.
And
Another question came in regarding trauma destination policy. Specifically, the question was about if there's any trauma centers out there about bypassing to go to the trauma center and how it applies to burn patients. The current field trauma triage guidelines, there is no bypass destination based on these burn patients, so it's to the closest hospital. Again, the new guidelines are coming out down the road. Again, this may change, so that will be something to stay tuned for as the new guidelines do come out.
Okay, were there any other questions that are out there?
that's all from this end.
Just give it a moment and see. Okay, well, hopefully that's everything, guys. Thanks for paying attention today. I really appreciate it, and thanks for letting me come in today and chat with you. Okay, take care. Bye-bye.